Alright, we're going to get started by going over some of these PowerPoints. I'll have a short video kind of overlay with some audio just to help key you in on some important parts and maybe some interesting facts or things you need to kind of focus on. Obviously today we're going to start with the chest x-ray. It's the most commonly ordered exam and the most repeated simply because of the volume that you do. You're going to start with learning the chest x-rays in your clinic, and you'll have plenty of practice as you try to get a little bit better and better with your collimation, but also the proper field size, the markers in the right spot, all the different chest views that we do as well. The basics of this, just make sure you identify yourself. The introduction is going to be part of your practical exam, so you need to make sure that you go through all of these things. You know, use proper shielding, ask women in childbearing years if they could be pregnant, and then go ahead and make sure your room is set up while they get dressed, including your technique and the cassette, marker, all that stuff. Patient prep for this exam is pretty simple. Everything from the waist up off. You need to look at all those things on there. Make sure you don't have to say every single one, but you do have to be clear about your instructions and making sure a patient doesn't forget something like a necklace that you see in this bottom image here. You're going to see that at some point, just because some patients won't listen to you or you'll forget to double check, etc. Some anatomy, you'll need to be responsible for all the anatomy within the chest. Some of the things to key on though are 12 pairs of ribs are articulated with the 12 thoracic vertebra. There's some other bony anatomy, including the two scapula, shoulder blades on the back, and then the collarbones or clavicles in the front articulating with the sternum, which also articulates with most of the ribs. The right lung has 3 lobes in it. The left lung will have 2 lobes in it, and that's mainly because of the size of the liver that takes up a lot of the space over on the right side here. This is actually going to be a little bit smaller. It's broken up into 3 sections as opposed to the right or the left lung, which has 2 lobes in it. Mediastinum includes those 4 things there: thymus gland, heart, trachea, esophagus. The esophagus is going to be posterior to the trachea, so if you remember that, you'll have your trachea in front and then the esophagus right behind it. Apex and the costovertebral angles, these are going to be your 2 areas. You're going to look at the apex, make sure the very top of the lung is on there, all the way down to the bottom, and this terminates in the costovertebral angle towards the lateral border on both sides. So you need to have everything from the apex to the angles on there. It's our basic look at most of the exams. Will have one sheet on it that has most of the information, so these are going to be important. Make sure you're at a 72-inch SID. That's the source to image distance. That means how far away the tube is from the patient. It's going to be 14 by 17 cassette. The LW stands for lengthwise. So what we have is we have our cassette longer this way normally than side to side. That's going to change based on the patient's habitus, but most of the time they are going to be lengthwise. Patient's going to be facing the butt key. Technique is on there. AEC just stands for automatic exposure control. That means the computer is going to figure out where or how much mass to give the patient. And we'll get into that in basic radiology. But it's going to put the cell basically one here over this part of the lung, the other one right here over this part, which is all over air, so it should give us a nice consistent look so that we don't make this image too dark, and we can see all the fine anatomy within the lung field. Shoulders, elbows rolled forward. That's really just to bring the scapula out of the way, so you want to make sure that the scapula is pulled out of the lung field so we don't confuse that with the pneumothorax. Feet apart, chin up, 8 to 10 posterior ribs should be seen. So these right here going down this way are the posterior ribs. They're going to go towards the outside of the body all the way down. So if we count the ribs all the way down, you should see 8 to 10 of those. Include apices to angles again. Central ray should be about T7. So your centering point should be right about here. Patient should be in full inspiration, so make sure you get 2 breaths in. You should see 8 to 10 posterior ribs or 5 to 6 anterior ribs. As we look at these ribs, as they go to the outside, those are posterior ribs, but if you look and they start to loop back in, those are going to be your anterior ribs heading back in. So you're going to see a lot less anterior ribs than you will posterior ribs. Centering should be directed to T7. That means the thoracic vertebra number 7. What you can do is you can palpate the vertebra prominens, which is a little bump on the back of the neck that most people can find pretty easily. And you use kind of this hang loose sign and that usually will measure right down to your central ray area, which should be about T7. The inferior borders of the scapula, if you can find those, you can usually palpate those a little bit, which means you can find them by touching them, is usually a good secondary landmark. I wouldn't use that as a primary landmark, but secondary landmark, definitely worth it. Lateral view of the chest, it's always going to be left lateral. The heart's more on the left side, so we want to detail that by putting that closer to the bucky. Most of the stuff is the same here, except we are going to use center cell as opposed to outer cell. The lungs are right in the middle, so what we want to do is we want to put the cell right in the middle of the lung field. If we put it on the outside, like on the PA chest, then you end up hitting air and a little bit of bone. So this way we stay right in the middle of our image. Arms should be raised up overhead. Shouldn't see any soft tissue. Include the apices, which are going to be washed out by the shoulders a little bit, all the way down to the angles. And usually the posterior portion of the angles are going to be the lowest point. Let's see. Marker, upper outside on the left side. So your marker should be up in this area right through here. Next slide will give a better look at it. This is what it looks like with your patient standing against there. Listen for the audio beep. You want to make sure you're watching your patient all the time when you're making exposures. During any exposure that you're going through, because the patient might not hear you, or they may just be doing their own thing, whatever it might be. They might be distracted, so you want to make sure that they are taking deep breaths then. Arms should be as high as possible. This could probably go up a little bit higher. You can see probably that there's going to be a little bit of soft tissue here. So if she slides her hands forward and gets her wrists a little bit higher on there, that will actually raise her arms a little bit more. This shows you an ideal versus a rotated image. You should have these superimposed on top of each other, which means they're both overlapping, as opposed to this one down here where you can see one lung here, the other lung down here, which means they're standing slightly askew, kind of creating this space between the ribs. So this is the posterior rib here, this is the other side of the posterior rib. This just goes into it a little bit more detail. Body habitus. This is going to be different types of body that patients have. Most of the time they're going to be the sthenic body shape here, which is about 50% of the people. Just normal size. If you look at the lungs, they sit generally pretty straight up and down so that we can use our lengthwise orientation. So that means 17 inches up, 14 inches across. But if you get a hypo or hypersthenic patient, they have the exact opposite. They're a little bit more burly, a little bit more stocky, and the costophoric angles sit a little further apart. That's when we will put our cassette in transverse or crosswise, or another term is landscape. Anatomic position, just when you're looking at images, this is how you're going to present yourself when you're looking at the films. So as you're facing somebody, the right side will always be over here, left side will always be on this side here. So we are going to hang all of our films according to this anatomic position. Make sure that you get your markers from your clinical instructors. You're going to use these markers. They need to be on every single image that you do. It's unacceptable not to use your markers or to have them coned off or outside of the field where you can't see them. There's some other positions we'll be looking at. Lateral decubitus chest. We'll explain this more inside the classroom, but basically this is a sideways view of the chest where they're lying down on either their left or right side. This one here, this lady is lying on her right side, so that would be a right lateral decubitus chest x-ray. These are good views for evaluating pleural effusions. So if they have a little bit of liquid in their lungs and we lay them on their side, you'll be able to actually see a layer across and see which lobes it happens to be into. Right lateral just means right side is down against the table. Arms both need to be up. Build up the downside either with towels or foam sponge. So you need to lift it up so that they can raise them above the top of the table so that you can see the outside part of the lungs. These are usually done bilaterally, which means we're going to do one side, right side down, and then we'll do the left side down. This is an AP semi-erect, usually done portably or in bed or during tabletop sitting, using the cassette behind the patient. So you'll be doing plenty of portables. We'll have our own separate portable demonstration when we get into the lab classes. It should look very similar to your PA and lateral films though. AP view, this is not commonly done, but they show it on here anyway. There's a trauma situation where they cannot stand up and you can't tilt them up because of blood pressure, or maybe they're bleeding or shot or something, then you can do a perfectly acceptable film lying down. You usually will not get the size of the chest on there, but that's okay in a trauma situation. Lobes and fissures. Lobes are just different sections of the lung. Fissures are just the divisions between those lobes. So on the right lung, you should notice that you have 3 lobes: superior, middle, and inferior. Left lung, you have a superior and inferior lobe only. This just shows a demonstration graphically of where those fissures are normally. You can't always see them when you're looking at the chest x-ray. Sometimes they will stand out when you see pathology though. This one, same thing. Graphically shows the right major fissure, right minor fissure on there pretty well. Other items to keep track of: make sure the arms are up. You can see the soft tissue overlapping part of the lung field here, which is no good. So make sure that it's up. We can use IV poles, maybe another person to kind of help hold the arms up, but you want to make sure you can see the entire chest. Chin, self-exclamatory. Apical orthotic view. This is really just to see the very tops of the lungs. What you should notice on this image here is that we can see the entire apex without the clavicles in the way. If we go back to the last image, normally the clavicles sit over the first 2 or 3 ribs on there. So when we do our apical orthotic like this position, we're able to see that area a little bit more clearly. Rotation. We're going to look for rotation with the medial ends of the clavicles that are outlined here in the spinous process. So basically we want this space here to be equal to this space over here. If it's not, then they probably have some type of rotation. Whether it's acceptable or not will be dependent on what you're looking for. This just shows a little bit of rotation, so you can see clearly the rotation here. We've got a lot of space between this side and this side, no space between here. So the patient is slightly rotated. It does talk about tension pneumothorax, so the shoulder blades, you need to make sure that those are out of the way as well. Some other pathology, just mass versus infiltrate. You can read up on that on your own, as well as pneumonia, common finding in chest x-rays. This just talks about having the proper amount of breath in, so you make sure they take 2 breaths in, or you can hide something that actually is not there, and then the doctor would misdiagnose this patient. Pleural effusion, just some water or liquid within the lungs. Nice clear air fluid level going on across here. If you see straight lines, that usually indicates air fluid levels. Cancer. Gave up after first nipple ring. This will definitely get you dropped from the program. So, like we mentioned in my lab, for some of you, don't be stupid. If you don't have an order, do not x-ray anybody you're not supposed to. If you have questions on this first PowerPoint, then let me know. You will have to look at the video to catch a few things, but also you should be going over these PowerPoints on your own, which will be posted separately. And again, if you have any questions, make sure that you just email me or contact me in class if you happen to be in my lab.